Hey guys, what's up? It's Stephanie. Welcome back to my channel today. So in the video today, I'm going to be discussing how my fourth month in a physician assistant residency slash fellowship was. Hopefully this video is helpful for you. For those of you, especially who are wanting to pursue a residency slash fellowship in a specialty after graduating in PA school or currently in PA school right now, or even a pre-PA student who is interested in doing that. So I will be discussing basically how my fourth month has gone. If you're curious, I'm going to add a link below that describes how my first, second, and third month have been in a PA residency slash fellowship. So just real quick, a little bit about me. I am currently a physician assistant who graduated in December of 2020. I decided to pursue a critical care medicine residency slash fellowship because I knew how huge the learning curve was going to be as a new grad trying to get a job in a critical care medicine department. Definitely doable, but it's a lot more harder. And I wanted to make sure I knew a lot about critical care medicine and I was well-rounded, so that's why I decided to do a residency slash fellowship. And I have to say that I'm pretty glad that I've done it. And the reason is because I've learned so much. I've made so many new relationships, whether it's been with PAs, other nurse practitioners, doctors from different specialties. I've gone through a lot of specialties so far through the APP residency, and you get to create long-lasting relationships with either residents that you work with, fellows you work with, or even some of your attendings, or like I said, other nurse practitioners or PAs. So highly recommend it. I'm very happy that I've done it, but I do have to say that the workload is very hard, and like I discussed, that learning curve is really hard. So that is just a little bit about me. I am currently in my fourth month. I actually just completed it, so I'm about to start my fifth month. So look forward for that fifth month video in regards to how my residency is going. So far, what specialties in ICU have I completed? So my first month was in the surgical trauma ICU. Basically, we got a lot of patients, like it sounds, surgery patients, surgical trauma patients. So we worked a lot with orthopedic and acute care surgery. So we would have patients that would have gunshots to the head, for example, gunshots to the face, dog bites, a lot of fractures, very scary fractures. So you got to really review your scans, their CT abdomen and pelvis scans, your x-rays. So that was my first month. The second month, I did neurotrauma. So I got really good with my neuro exam. Neurotrauma, we saw a lot of spinal cord injuries, traumatic brain injuries. My third month was in the neurovascular ICU. So patients that we saw in the neurovascular ICU were stroke patients, a lot of patients that had any type of head bleed, whether it was, for example, in intraparenchymal bleed, subdural hematomas, epidural hematomas, but of course a really severe kind. We also saw a lot of patients that were in status epilepticus, really weird diseases that I had never heard of or I had read about, but I never thought I was going to see in person. So West Nile virus, which is really common up here in the north where I'm attending the program at. And in addition to that, I saw a lot of status epilepticus, so I got really good at learning how to treat patients that are having just regular seizures and then patients that are going into status epilepticus. So I really like this rotation a lot. We worked really close with neurosurgery and neurology. I learned a lot from neurology in regards to how to read a scan, MRI, CT head of the brain, MRI of the brain. What's the difference between a CTA of the brain? What are the different types of MRIs that you are getting for patients who are in stroke, like DWIs, etc. And I also got really good with my neuro exams, and I really like this rotation so far. Definitely neurotrauma and vascular ICU have been by far my favorite rotation. So I'm currently in the surgical ICU. It's different from surgical trauma ICU. Surgical ICU, we see a lot of, just like it sounds, post-surgery cases. We would see a lot of patients, especially that have any type of thoracic procedure, whether it was having a part of their lung removed, for example, because they have a history of cancer. The majority of them, though, that we saw had problems with their esophagus. One of the physicians I work with at where I am attending currently my residency is well known for inventing the minimally invasive esophagectomies, for which we saw a lot of patients of his post-operatively. So a lot of these patients have a history of some type of cancer or esophageal cancer, and they would come to us post-operatively to manage them. And like I said, any type of patient that had any thoracic issues, any abdominal surgeries also. So usually your Roux-en-Y, your bypass, your gastric bypasses that went wrong or that were fixed by our surgeons, etc. So these were kind of the majority of the patients that we saw. I will be honest, this was definitely not one of my favorite rotations. I'm not a huge fan of just thoracic surgery in general. I don't find that interesting. But I do have to say that at night, you would take care of the patients that were in the CT ICU, so the cardiothoracic ICU patients, and that I really liked, which is my next rotation for which I'm really excited about. So a lot of the patients that we took care of at night were, like I said, cardiothoracic ICU patients. So it would be your patients that would get heart transplants, lung transplants, that had CABGs, coronary artery bypass grafts. So I really like those patients that were connected to ECMOs, especially since I did this rotation between October till November. During that time, that's when kind of the COVID peak was rising. So like we saw a lot of patients that had really severe COVID or ARDS, and if they did qualify, were on ECMO. And most of these patients, unfortunately, that were on ECMO, they did not survive off ECMO, unfortunately. So this was very sad, but it was really interesting because you got to learn just how the ECMO machines work and what's the difference between the different types of ECMO machines. And I really like that about this rotation, surgical rotation, is because at night we take care of the cardiothoracic patients, but during the day, not a huge fan of any type of thoracic procedures, right? So for example, other patients that we take care of were patients that had chylothoraces or hemothoraces that needed to be removed, patients that were post-VATS, right? Procedures, those were kind of the patients that we took care of. And the ICU was very small, so we had about 8 patients. Usually, sometimes we wouldn't fill all the beds, sometimes we would, and this is very small in comparison to, for example, the neurovascular ICU where we had 20 beds versus, for example, the surgical trauma, which is where I did my first ICU rotation. We had 22 beds. This was definitely a smaller ICU. Another thing that I do have to say that I did like, though, is that this ICU was run merely by APPs. So APPs ran it during the day and at night. So you had a PA or a nurse practitioner running it in the morning and then at night, and you were basically working independently. And that's what I really liked about this rotation. So you would round on the patients in the morning with your nurses, and then of course the attending would come and you would go over your plan with the attending, and the attending would say, you know what, this is what I would do instead, or kind of just give you hints or tips on what they would do instead. So that's what I really liked about this rotation, is that you are practicing autonomously versus the other rotations. You have an attending, you're rounding with the attending during the day. So that's one of the pros about this rotation. But just the medicine, like I said, I'm not a huge fan of thoracics and didn't really like this rotation. And then in regards to my hours, so these shifts were longer. We worked from 6 a.m. till 6 p.m. Sometimes we would get out a little bit later, so there were 12-hour shifts. Good thing I only did 5 12-hour shifts, so that was nice, so I had 2 days off. But still, it ruined your whole day, because I go in, I wake up at 4:30, right, and then I start getting changed. And then once I get to work, I have to park in a parking garage, and then I have to take that bus from the parking garage to the hospital, so that's about another 10 minutes. And then by the time you get to the hospital, it's like 6. And then when I get off, I'm getting off like at 6 or 6:30, and I have to do the same thing. I have to wait for the bus, and sometimes in the afternoon it takes a little bit longer. So sometimes you can be waiting up to half an hour at that point for the bus to come by and pick you up. So sometimes I won't get home until 7, 7:30 or 8 and then I have to get home, shower, and then go to sleep, and then it's like the same thing. So that's what I kind of didn't like about this rotation, were the long hours and the fact that my day was almost gone the entire day. So that was one of the cons also. But on the positive side, you got 2 days off. So that's what I liked about this rotation, is that you get 2 days off. So overall, I learned a lot. I definitely learned how to take care of patients that are post-surgical, especially your thoracic patients, or any patient that has any type of abdominal surgery, any type of esophageal surgery. You have to be very careful, of course, of feeding them and when you can start feeding them, right? And then most of these patients have really weird surgeries, which I had never heard about in my life, and they have a lot of drains everywhere. So you get really familiar on how the drains look, what the drains are, right? And how to basically call thoracics if there's something wrong with the drains, and that's a pro. And like I said, the other pro was that you get to work along APPs, so it's solely run by APPs, and that's a huge plus because I got to do a lot of procedures. You're not fighting for procedures with other residents or fellows. Every procedure that came in, whether it was a central line, whether it was a femoral line, whether it was intubating a patient, whether it was having to do a bronchoscopy, you were able to do all of these. So that's what I really liked about this rotation. And I do have to say that I got to do my first intubation during this rotation on a real human being. Of course, we're taught to do it on dummies, and my first month I even was taught to do it on cadavers, but never on a real patient that's crashing, an unstable patient. So I was able to intubate my first patient that was actively crashing. And I have to say that it was definitely nerve-wracking because I had to do it with, of course, once you do critical care medicine, you'll learn about the different ways that you can intubate. You can do it with lidoscope, etc. There's several ways, but with this one, I had to do the direct, right, which is what we learn in PA school. And so I had to do it with the direct. And of course, I wasn't able to get it the first time, and the patient's actively crashing, and it was even more nerve-wracking, but thankfully the doctor was with. He was very, very patient with me, and I was able to get it on the second try. So I was able to intubate my first patient. So that's definitely a huge learning curve. All right, I hope this video was helpful for you guys. If you have any questions, feel free to comment below. And I apologize, I've been so busy, I haven't been able to get back to all the comments I've had. It's just this residency has been really busy. And the days that I'm off, I'll be honest, I'll sleep all day. But I will get back to you, and take care of yourselves, and I'll talk to you later. Bye.